Should we wait some more time? Can start. Dr. Are you ready? Dr. Pragya?
Yeah, tell me.
Yeah, we'll start then. It's 10 now.
Yeah, absolutely.
Okay. So we will start the YouTube streaming also. We can start. Okay. Okay. Good morning, everyone. For the today, I am more privileged to introduce our who is senior consultant medical oncologist working with Muzamdar Shah Cancer Center in Narayana Health City, Bangalore. She has completed her MBBS from MS Ramaya Medical College, Bangalore, and MD in General Medicine from Andhra Medical College. She completed her DM in Medical Oncology from the prestigious Nizam's Institute of Medical Sciences in than 10 years of experience in treating oncology patients at NH, where she has been working since the last 6 years. She specializes in the treatment of adult oncology patients. Her areas of interest are breast, lung, and gastrointestinal cancer. She has an cancer clinical trials and translational research. With this, I also like to share that we have worked on triple negative breast cancer, one of the proposal which we have sent to ICMR. In this, we have really had a major challenge, and probably that could be today we can throw the challenge to the students for hackathon also, so that we can develop some proof of concept which was lacking for the funds to come. So that can also be a part of this particular webinar. In this now, I just give the mic to Dr. Pragya, who is going to give you a brief introduction on companion medicine as well as the personalized medicine. Thank you, Dr. Pragya, for your kind giving some time for the students and also throwing some insights on them. Thank you. Over to you, Dr. Pragya.
Thank you so much for that introduction. So I'll just start my slide sharing first. I just want to see. Okay. Yeah. 1 second. Let me just check if a minute here. Yeah.
Take your time. It's fine. And just take it.
Slide.
See. Slides.
Can you see?
Oh, yes, Dr. Pragya. It's starting to share content. Maybe in a way it will come.
Can you see the slide?
Yes, we can.
We can.
Yes.
Yeah. Okay.
You can see the slide.
Then I'll start off. Put it on play. Okay. So good morning, everybody. Today I'm going to be talking about a topic which was given to me, which is the concept of personalized medicine and the need for companion diagnostics. So to put it in a nutshell, this is what the entire concept of personalized medicine is about. It is about this sentence that one size doesn't fit all. Am I audible to everybody?
Well, you can continue.
Yeah. So what this essentially means is that not even though patients may have the same type of tumor, not everybody has the same outcome from their disease. So each patient is different, each tumor is different, and one size treatment does not fit everybody. So let's just, I'll just start with a brief illustration. So commonly in the clinic, we see breast cancer patients. I'm sure all of you all have friends or distant relatives who might have suffered from this disease. Now, breast cancer essentially is, that you'd see different types of patients in breast cancer. So one type of patient, you might have heard that she was breast cancer, she had surgery, she had chemotherapy, she had radiation from her disease for more than. And then you would also hear another type of story where this patient with breast cancer was diagnosed with her disease. She also received the same treatment, that is surgery, chemotherapy, radiation, but then unfortunately uh, she succumbed to her disease within 2 years after the diagnosis. So essentially, both patient A and patient B had the same diagnosis, which is breast cancer, and they were treated very similarly, which is surgery, chemotherapy, and radiation. So, what makes patient B different from patient A? So, that is where the entire concept of personalized medicine is coming in. So, to find out exactly what each individual patient has or what each individual tumor has, and what features in those tumors can help us to treat these patients better. So this is the definition of personalized medicine. So personalized medicine essentially means using medical products and practices that are going to be tailored to match the features of the disease. Not just oncology, personalized medicine is there across all branches of medicine. But since this talk is related to oncology, we will focus mainly on the oncology part of personalized medicine. There are other names for personalized medicine. It is also called as precision medicine, individualized medicine, and even genomic medicine. So the current abbreviation for this is PPM, which essentially stands for personalized precision medicine. So that's what it basically. Um, so this is just to illustrate how medicine has changed along the ages. So previously in the past, maybe 50, 60 years ago, doctors used to treat patients with symptoms and they used to give based on symptoms. So presently, we are a little more advanced than that. So we have population-based studies, which are called clinical trials, and then we prescribe certain treatments, and those treatments which work in a majority are considered to be evidence medicine, and we treat based on evidence-based medicine protocols. But the future may not be either of these. The future seems to be precision medicine. So precision medicine is where we individualize a patient, individualize a tumor, find out what exactly are the features that are present in these patients, in these tumors, and then use big data algorithms to actually treat these patients in the future to give the best possible treatment for these patients. So now that you know what is personalized medicine, how is it helping us in oncology? It is actually helping us in every step of oncology. So it is helping us to know who are the patients who are at risk, who are which patients can, which cancers can we prevent. It is helping us to find cancers early. It is helping us to diagnose cancers early. It is even helping us mainly right now where we are using it largely is in helping us to choose which treatment works best for these patients. So that's what we call as targeted therapies, where we're trying to find targets in these patients and trying to use drugs that are basically going to latch on to those targets and kill those targets. And it's also used for monitoring results. So just to give you a small illustration about, I just take one out of these examples. For example, let us start with the first one, knowing who is at risk. So commonly we have patients with a family history of breast cancer. Patients, it is still quite common. And in these patients, what we do is we take their family history, we send them to genetic counselors order a battery of tests, gene, BRCA1 or 2 commonly mutated patients. So this is where personalized medicine helps us. Once we know that the patient is BRCA1 or BRCA2 positive, we have certain protocols which can help us to prevent cancers in these patients and also try to find these cancers early. So we prevent cancer by subjecting some of these patients to prophylactic surgeries. That means surgeries before the disease actually occurs, like prophylactic mastectomies or prophylactic oophorectomies. And we also try to find cancers early by doing more intensive screening starting early in these patients. So this is one of the just many examples where personalized medicine helps us in oncology. So if you think that precision medicine is maybe too far off and actually we are not really there, you have to think twice, because the shift to precision medicine is actually happening right now. Cancer care is increasingly becoming more and more complex as more and more targetable genes are being identified. So, like I said, in the past, cancer was basically defined by something we call histopathology, and then we treat it primarily with cytotoxic chemotherapy. And you know that most patients do not like chemotherapy. So, nowadays, across tumor types, we have molecular targeted drugs that are being prescribed at least to subset of patients. So, some of the examples of molecular targeted drugs are trastuzumab, imatinib, erlotinib, and vemurafenib. So just to give you an example of where and how we are going towards that place, in 2017, there were 700 molecules in late stage drug development, and 90% of these molecules were, surprise, surprise, targeted treatments. So there is an urgent need. So now that you have these molecules, there's also an urgent need for diagnostic tests that will help to identify genetic alterations in individual tumors and most importantly, match the patient with the available targeted therapy. So what are these diagnostic tests basically called? These diagnostic tests are basically called biomarker tests. So biomarker testing is in essence the center of personalized testing. Biomarkers are basically anything, any of the body's molecules that can be measured to either assess health or disease. Here we are talking primarily of oncology, so we call them oncology biomarkers. They can be obtained either from blood, either they can be obtained from body fluids or from tissues. So I've shown a small illustration where you have the different types of biomarkers. They can be small proteins, they can be enzymes, they can be DNA, that is slices of DNA, which we call genes, or they can be RNA, and they can be even cancer cells, circulating tumor cells. They're also biomarkers. So the other name for biomarker testing is they call either molecular testing or genomic testing. I've kept this talk very simple because I understand that the target audience is non-medical. In case you have any questions, please feel free to interrupt me during the talk, or even if you have questions that go beyond this talk related to personalized medicine, please ask me at any time. So again, to illustrate how biomarker testing is helping our patients. So if you look on the left side of your screen, you're looking at essentially what is the standard treatment that is happening now in cancer patients. So you have a population of patients, you prescribe a therapy. The therapy seems to work in the majority of patients. In some patients, it has an effect. In some patients, it stabilizes the disease. But in some patients, it actually has adverse effects. So whereas when we use biomarker diagnostics, we test the population of patients, we can actually put them into subsets of patients where the correct therapy can be given with maximum effect. So, what are the types of biomarker tests? So, you know, what is personalized medicine? We have learned that biomarker testing is the essence of personalized medicine. So, what are the types of biomarker testing? So, essentially, you have very basic, to tell you very basically, it is best, there are essentially three types of tests. You either have chromosome tests, you either have gene tests, or you have biochemical tests. So chromosome tests are essentially used to detect structural changes in the genome. Gene tests are used to detect abnormal features of gene products, and biochemical tests are used to detect abnormal biochemical effects of the tumor. So I'm going into these individually, just very briefly. So the first type of biomarker test is a chromosome test. So in cancers, chromosomes can be either erased, they can be deleted, or they can be expanded, which we call fusions, or they can be switched, which we call translocations. So to give you an example, there is a very famous chromosome, which is called the Philadelphia chromosome, which we see in a group of cancer chronic myeloid leukemia or CML patients. And one of the tests that is used to detect this Philadelphia chromosome, although it is a very old test, and nowadays there are other tests that supersede this. One of the tests that we use is something we call bone marrow cytogenetics. If you see in the picture over there is a 922 translocation. The short arm of chromosome number 9 has attached to the short arm of chromosome number 22, and that shortened chromosome 22 is what we call the Philadelphia chromosome, and that is the one that drives the tumorigenesis in CML patients. And this simple test, which is bone marrow cytogenetics, is used to detect this Philadelphia chromosome. So another type of biomarker test is something we call gene testing. So gene testing is either you're trying to assess either one gene or a short piece of DNA. Now these tests look essentially for extra gene copies, which we call duplicated or amplified genes. They look for missing genes, which we call deletions, or incorrectly placed genes, which we call translocations. And these tests also look for small altered steps in the DNA ladder. So you know that DNA is double-stranded. There are base pairs. A attaches to T, C attaches to D. So any alteration in these steps, which we call gene mutations, these gene tests are essentially there to detect these changes. So just to give you an example of where we use this biochemical test, most commonly we use it for testing HER2 gene amplification in breast cancer patients. That is what I've shown in the picture. So this is an in situ hybridization or a fluorescent in situ hybridization, which we call FISH. In the FISH positive patient, which is on the left side, you can see a lot of red signal, which is basically the HER2 gene, which is amplified in these patients. Whereas on the right side, you can see that the HER2 is negative. There are essentially the HER2 copy is not as much as in the previous slide. So this patient on the left side is called HER2 positive breast cancer. Another example where we use this test or this biomarker test in the clinic is to test EGFR mutations in lung cancer patients. And this is used to tailor treatment based upon the mutation presence or absence. So the third type of biochemical test, a biomarker test, is something we call as biochemical test. So in some cancers, because of the abnormal genes, they can be overreactive proteins that can be detected using biochemical tests. A very simple example, I'm repeating again from the previous slide. We saw that HER2 gene amplification was detected by in situ hybridization, which is a gene test. Here, the same HER2 gene in the same type of breast cancer patients can also be detected by strong staining patterns on something we call IHC or immunohistochemistry. So you can see the four pictures over here. In cell line A, there is no staining for this particular protein or the human epidermal receptor protein. In cell line B and C, it is a faint staining. But in cell line, if you see in cell line D, it's a 3+ staining. That means there is heavy staining of HER2 protein because of strong amplification of the gene. So this is an indirect measurement of the gene amplification. Although the FISH test is considered the standard and the IHC is considered to be the first step. Now, and the confirmatory step is the FISH step. So coming up, we have learned what is personalized medicine. We have learned what is biomarker testing, what are the types of biomarker testings, and now coming to what are the relevant genomic alterations in cancer. To simplify the entire thing, I've just said that there are 4 major types of genome changes that basically cause cancer. So either you have a base substitution, which is what we call mutations, or you have insertions and deletions, which we call indels, or you have copy number alterations. The number of genes is altered, which we call CNAs, or you have rearrangements or translocations. So to simplify it, these are the 4 main genomic alterations that you see in cancer. There are, of course, some other alterations like which are pan-tumor and which are a little more complex to detect, like tumor mutation burden, like microsatellite instability. But to keep the talk simple, I've just focused on these 4 major alterations: base substitution, insertions and deletions, copy number alterations, and rearrangements. So if you use, so far we have learned about single biomarker tests, like either tests, or you have gene tests, or you have biochemical tests. So sometimes these single biomarker tests may not be enough to detect all the relevant all the relevant genomic alterations in the cancer, and you might miss some critical alterations that can actually change the outcome for the patient. So nowadays, what we advocate, or what precision medicine is heading to, is something we call next generation sequencing, or we shorten it as NGS. So what is this next generation sequencing? Essentially, it is a massive parallel DNA sequencing, which is done to elucidate all the genomic alterations of therapeutically relevant cancer genes in a tumor. So I'm just moving to the next slide just to show what it exactly is. So the previous type of DNA sequencing is what we used to call the Sanger sequencing. And nowadays, what we're doing is something we call next generation sequencing. To keep the technicalities short, I'll just briefly talk about it. So what you take is you denature the DNA, you prepare a library using ligation, and then after that you amplify certain clusters and you analyze those clusters. So essentially this is what it is. So with this, we try to identify commonly altered along the whole genome sequencing. We try to find out altered spots. So just to go back to the previous slide, so there are, see, if you take it in a research setting, you have the privilege of finding out only where you have high tumor, and you can do those kind of, you can do a sequencing more easily. Whereas in a clinical situation, you're looking at a patient who has very small amount of tissue. You have very small amount of tissue. Either the tissue is in something we call formalin fixed paraffin extracted, or FFPEs, and these samples usually damage the DNA. So getting DNA from these samples may be actually tricky. or majority of the samples that you get in cancer patients are very small core biopsies or cell blocks where you have very limited amount of tissue and DNA. And the challenges, there are a lot of challenges for NGS in this setting. So given these challenges, we have to make sure that your tumor genome sequencing at least has a robust DNA extraction, and it also has a well validated algorithm analysis. So we use certain commercial NGS assays, though they are very, very expensive, and all the samples are actually imported outside, exported outside India. The tests are done outside India, and they sent back the results. So two of the most commonly done NGS assays are Foundation 1, which we call F1. This is a test that sequences clinical tumor samples to characterize. These are all FDA approved tests. That's why I've taken these two. There are many others as well. It basically takes the tumor samples and it characterizes the exons of at least 315 cancer associated genes and introns from 28 cancer genes that are involved in rearrangements. There is another commercially available assay which is called the Garden 360, which is abbreviated as G360. It uses cell-free circulating DNA from blood and it helps to sequence 70 genes. So both F1 and G360, they have high specificities, which are more than 99%, but they have somewhat lower sensitivities. And one of the other, some of the studies are showing that there is actually very little concordance between the two tests. So two tests are possibly not very concordant. So now it makes us, now they are in a tricky situation as to what to order and how to order. So other than next generation sequencing, the other important thing that is happening nowadays is something we call companion diagnostics. These are, of course, biomarker tests, which we have discussed previously. They are assays that measure the levels of proteins, genes, and specific mutations to reveal certain types of specific efficacious therapy for cancer patients. So what it essentially means is, again, you're using the biomarker test to essentially target a particular treatment for the patient's cancer. So one example already, which I've mentioned many times, is the HER2, and the other example, which I talked about in the risk thing, is a BRCA analysis. The BRCA analysis CDX comes from Myriad Genetic Labs. It helps to detect and classify DNA variants in protein coding regions of BRCA1 and 2 genes, and this helps us to make a lot of clinical decisions, not only from screening and prevention, but also for treatment of these patients. So nowadays, other than biomarker testing, other than next generation sequencing, other than companion diagnostic tests, the next big thing that is happening in oncology is liquid biopsy. So liquid biopsy essentially means tumors, every person's must shed certain circulating tumor cells that we abbreviate as CTCs, or circulating tumor DNA that we call ctDNA. And these have now emerged as a face of the liquid biopsy. So instead of taking out a tissue biopsy, you're now taking a blood sample, and that blood sample you're going to look for these circulating tumor cells or the ctDNA. In some studies have demonstrated that there is high rate of concordance between the liquid biopsy and the tissue biopsies. So essentially, a liquid biopsy may be good enough, and you may not have to subject these patients to a tissue biopsy. So when in some way, especially in elderly gentlemen who have already received many of these biopsies previously, we cannot go on doing tissue biopsy. So this is where liquid biopsies become a, and they can allow repeat genetic profiling to detect what was the response to the treatment, what is the type of evolution the tumor is growing to, are there any drug resistant mutations. So this is, and also it can help us to integrate genomic signatures for multiple metastases. So when we do a tissue biopsy, we're essentially taking a biopsy from one site, but when we do a liquid biopsy or a blood biopsy, we may be getting the genomic signature from multiple sites. So this may help us to tailor the treatment better for the patient. So it has some advantages, but there are also some challenges for liquid biopsy. One is there could be a rarity of the biomarker. If you're looking at CTCs, that is circulating tumor cells, the frequency in blood is at 1 cell per 10 to the power of 6 to 10 to the power of 7 leukocytes. So for every 10 to the power of 6 leukocytes, you have one CTC, which means that it is quite rare to detect this cell. CTCs can also be damaged during sample enrichment and isolation, just like DNA. And mutations from clonal expansion of benign cells can confound the data for mutations in these tests. The biggest question is, after learning what is precision medicine, after learning what are the types of tests that we're doing, after learning what are the recent advantages, the biggest question is, are all these technologies actually benefiting the oncology patients? So unfortunately, we do not have any good data. Our clinical experience is very limited with respect to these because these are expensive tests. and does the cost actually warrant the use of these particular tests? So we have very few observational studies, one of which I have quoted here. This is from 2017, and observational studies have shown that there is some progression-free, what we call benefits in patients who have received precision medicine-based treatments compared to matched historical controls. So, so there are some limitations of personalized precision medicine. And what we need to remember is genetic tests are not perfect. Nothing is perfect, okay? Because some or most gene mutations do not perfectly predict outcome. Just because you found a mutation in a particular patient doesn't mean that by treating that particular mutation, you may change the outcome of the disease. So most gene mutations do not predict the outcome. This is what we try to explain to our patients whenever we order these tests. We say there are limitations to these tests. Yes, we may find mutations, but by blocking that particular gene, we may not always change the outcome of the disease. And the other thing is clinicians need to understand that every test has certain specificity and certain sensitivity, and sometimes we may not catch everything that is critically important for the patient. So I'll stop here. So that was the end of the basic talk, and I thought maybe to make it a little more interesting, we can do some clinical situations. So this you can understand what happens in the hospital. Any questions so far? Hello.
Yes, guys, please, if you have any doubts till now, please clarify so that the other slides will be much more interesting for you.
Or shall I finish this and then maybe we can discuss it together?
It's fine. Maybe they are
Ma'am, I had
overwhelmed
a
with
doubt.
so many information.
Yeah, please tell me.
Ma'am, what about cases of triple negative breast cancers where does it play a role there? Can personalized medicine be used there as well?
So we haven't yet started using personalized medicine in a big way across tumor types, so not specifically for TNBC. So TNBC is one of those problem areas in oncology where we most definitely need better application. So what we right now all we do is we are treating most of our patients with chemotherapy. The one new thing in treatment of TNBCs is that we are testing these patients for something we call PDL1, which is an indication of PDL1 positivity is an indication for use of immunotherapy in these particular patients. So that is the only new approved change that we are doing right now. But otherwise, across the tumor types, across most tumor types, we are not using precision medicine in a big way. But that is where possibly the most application is. That is where you should possibly be looking for more applications for precision medicine.
One more doubt, ma'am. Up to what stages can personalized medicine be used? What
It can
stage
be
is the
used in
cancer?
all stages, any
All
stage.
stages.
It can be used even in asymptomatic people for screening. It can be used after treatment for monitoring. It can be used in any stage. Even in stage 2 breast cancer patients, we do fish for HER2 to check whether they have the gene amplification. And if they do have the gene amplification, we have to use the targeted therapy for these patients.
Can
So
it be
all
used for so it can be used as a preventive method as well for those who have the mutation?
Of course. So we not for HER2, but for BRCA. So patients who have a family history of breast and ovarian cancer, we send them to the genetic counselor. We get their BRCA gene analysis done, and if they are positive, there are preventive surgeries that can help these patients. Not 100%, but close to 95%, which is very good.
Are there conditions for that, ma'am? Like age or like
Yes,
besides the...
yeah, there is criteria for after fulfilling those criteria, then only these patients are subjected to these particular tests.
No. Okay, ma'am. Thank you, ma'am.
Excuse me, ma'am, I had a small doubt.
Yeah,
Uh, a patient with a family history, and you were talking about the specific gene. So, in that patient, so my small doubt is that the patient who has a family history, does the person already have a mutated gene, or there is susceptibility of that gene to get mutated? And if it's both cases, then what is the way forward?
so of the total types of cancers we have, only 5% are generally considered hereditary, which means that 95% of them are not are not inherited cancers. They do not go across families or do not get passed across generations. So for that 5% of patients, we have strict screening criteria. So if you have 2 or more cancers, or if you have a history of 2 cancers, or you have 2 family members, or if you're presented with cancer at a very young age, those are the kind of patients for the gene. Otherwise, we don't test blanket gene mutation. Is the gene likely to get mutated if you have family history? No, I don't think you can say that outright. But you have to, if there are certain strong criteria, you would have to test the patient, see for the gene mutation, and then proceed based on that result.
Thank you, ma'am.
Excuse me, ma'am. So you mentioned next generation sequencing. Hello?
Yeah, can you hear me?
Yeah. So you mentioned next generation
Audible.
sequencing.
Varun, excuse me. Varun, you are not audible. You should, it's not clear. Please
Okay. So,
make a proper arrangement.
okay. Yeah. So you mentioned next generation sequencing as a tool for personalized medicine. So
Yeah.
recent studies have actually used transcriptomic data as well. So like high throughput sequencing data for RNA sequencing and even microarray data. And they've incorporated this along with the mutation data from genome-wide association studies.
Yes.
But the problem is that RNA-seq data is a bulk approach, right? So you're not, you can't generalize a patient's transcriptome by taking RNA sequencing data. So you need to take single cell sequencing data, which is really expensive. So I think that's the best way forward if you're looking at in next generation sequencing approaches in personalized medicine.
Possibly yes, but we're still far away from it. Mainly because so it needs a lot of validation. You need to you need a lot of standardization, a lot of validation. So as of today, we have only DNA based sequencing that is allowed to make clinical decisions. So you cannot base your decision on RNA sequencing, and RNA sequencing
Oh,
is
okay.
considered to be inferior as of today. So let me so as of today. So right now we are only using DNA based sequencing for making clinical decisions. But I
Thank you.
think the future may be what you said.
Okay.
Shall we move on to the case histories?
Sure, ma'am. Please continue.
Yeah, I'll just so I've said a lot of theory. Now I just want to show how we actually use this theory in the clinical practice. So I've just selected 5 random case histories. I understand that you're non-medical, and if you don't understand some of the terms, please let me know immediately. So the first case is a lady with breast cancer. So here we had a 50-year-old lady. She came to the hospital with a 2-centimeter left breast lump. So she was clinically staged as stage 2A. So as you know, there are 4 stages in cancer, which is stage 1, 2, 3, 4. Generally, stage 1, 2, and 3 are considered curable, and stage 4 is considered metastatic and incurable in most of our patients. Now, this lady had a very curable breast cancer. So the first step we do for these patients is we go in and put a core needle into the left breast lump, and we take out a biopsy. And the first thing we subject the biopsy to is something we call histopathology. So we confirm that she had invasive ductal cancer. Then the next step we do on these patients is that we always tell them all breast cancers are not the same. So we need to subtype your disease. So we do immunohistochemistry, which is what I spoke about, which is one of the biochemical tests we do. And then we test her for basically 3 genes, which we call ER, PR, and HER2: estrogen receptor, progesterone receptor, and human epidermal receptor 2. So when the results came out, we found that she was ER positive, there is a scoring for it, which we call she was 8/8, and there is a PR receptor. It was 7/8. So she was essentially hormone receptor positive. And she also had something called HER2, that is a human epidermal receptor 2. It was equivocal on IHC, and it was 2+. So remember, I showed you 4 pictures where we had a 2+ staining, meaning the test was insufficient to determine whether the HER2 was positive or negative. So here is where we use one of our most commonly used tools, out of the personalized medicine. So this is where we do something called as fluorescent in situ hybridization. We do it for the HER2 gene. And what we detected was the over-amplification of the gene. So like I showed you in the two pictures, one side the signal was over-amplified, the other side it was not. So when we saw this over-amplification, we called her as a positive breast cancer. She's also hormone receptor positive. So essentially, she's something we call triple positive breast cancer. But since she was a stage 2 disease, she underwent surgery, she had her chemotherapy, and most important decision we did for her is we gave her a targeted drug which we call as translucimab. This is a targeted molecular targeted therapy. It is an anti-HER2 therapy, so it essentially goes and clings on to the HER2 receptor and subjects it to cytotoxic damage. So we gave her this for a period of 1 year, and then we put her on hormonal therapy, which went on for 5 to 10 years. So this is actually a life-changing treatment for this patient. It's a life-saving treatment, life-changing treatment. So HER2 positive constitutes about 30% of breast cancer patients. And previously, before the advent of this drug trastuzumab, it was considered a very aggressive disease, and most patients used to succumb to their disease within 1 or 2 years, like some of the illustrations I gave you in the beginning. So now with the advent of this therapy and many more therapies after that, there are many more anti-HER2 drugs that have come into the picture. With the advent of these therapies, even stage 4 HER2 patients are crossing 5 years. So that is a major change by precision medicine in oncology. So this is one of the very beautiful success stories of precision medicine. So yeah, sorry, I'll actually put it on full screen. Yeah. So another common situation where we use personalized medicine nowadays, I'm talking about the present in the lab, is in the clinic, is in lung cancer. So just to illustrate, this is a story of a 60-year-old man. He's a non-smoker, and he was diagnosed with right upper lobe lung cancer. Unfortunately, by the time he was diagnosed, the disease had already spread to his adrenal glands. So he is actually a stage 4 disease. So like I told you previously, a stage 4 disease is considered to be an incurable disease, but definitely a controllable situation. There are treatment options available for these patients. And like I said previously, the first thing we try to do is we get a biopsy out and we confirm the diagnosis and find out what the histopathology is. So we did a biopsy and the tumor tissue was diagnosed as an adenocarcinoma. So he has a stage 4 lung cancer and adenocarcinoma. So this is where we use, whenever we see this diagnosis of an adenocarcinoma lung, the next step we do is ordering for a precision medicine testing. So this is what we order for. We order for EGFR, ALK, ROS1, and PDL1. So these are 4 genes. EGFR is epidermal growth factor receptor, ALK is anaplastic lymphoma kinase gene, ROS1 is a tumor promoter gene, and PDL1 is program death ligand 1. So these are the tests we order for. This is a panel we most commonly order for. Nowadays it has expanded, but this is what we are using in India. So when we subjected him to this DNA mutation testing, we found that he had an EGFR exon 21 L858R mutation. This is a very commonly seen mutation. It is a small base substitution. Okay, and what and this is this mutation is seen, we know that that is a driver for his tumor growth. So what do? We use something called as tyrosine kinase inhibitors. There is a drug called afatinib, which is a second generation tyrosine kinase inhibitor, and we used that for this patient, and the patient had a relatively symptom free 2 years. So this is one of the first steps. Next, moving on the same story. So what happened after 2 years? The patient started developing new lesions in his brain. So this is common because brain is one of the sanctuary sites, and it is one of the places where cancer can spread without an escape immune detection. So then his blood, so we did not take out a tissue the second time, we just took a blood sample and we tested it for drug resistant mutations. Why did he not respond to afatinib, which he did so well on 2 years? And then we found that he had a mutation called as a T790M mutation. So this T790M mutation is a reason for drug resistance to afatinib. So then what did we do? We gave him palliative radiation to his brain metastasis, and we changed his treatment to a third generation TKI, or a tyrosine kinase inhibitor, which is called osimertinib, which was one of the approved drugs for this particular condition. He did well on osimertinib for a period of time, but unfortunately he succumbed to his disease because this is a stage 4 disease with brain metastasis. But this is an illustration to show how the drugs actually helped him to live longer, and generally, the survival for an untreated stage 4 lung cancer patient would be less than a year. So this man actually went on to live for at least 3 to 4 3 years. So next, the third study is something is another very common diagnosis we've seen in the West. We see it less frequently here. This is melanoma. So this is a 70-year-old man. He was surgically treated for melanoma. Melanoma is a small tumor of the skin. He had a melanomatous lesion on his right foot about 2 years back, and at that point of time, surgery was done, and it was all forgotten. And then now he came back to us with shortness of breath, and he came back with cough. What we found on his CT was that he had multiple lung metastasis. So essentially, he's a stage 4 disease now. So what did we do? We put in a CT guided core biopsy into one of those lung lesions, and we took out a piece of tissue, and we confirmed that again it was the same melanoma that had come back in his lungs. So now, interestingly, melanoma is one of those tumors where almost 40 to 60% of them have a very unique mutation, which is called a BRAF V600E mutation. And this is one of the tests we order for whenever we see a melanoma stage 4 disease. So this tissue was tested for a BRAF V600E mutation, and it turned out to be positive. And this patient went on to be treated with a combination of drugs which we call as dabrafenib and trametinib. So here we see how precision medicine helped us to identify a gene and how targeted drugs were basically given to block those particular mutation. Unfortunately, two things about this. One is the drugs are very, very expensive. The cost of this particular combination for just 1 month is about 4 lakh rupees. So the patient gave up after a few months, and then he progressed, and then we had to go back to good old chemotherapy after that. So, but that is just so. Imagine if it was a different situation, that brafenib and trametinib would have worked for a longer period of time. So now another case study we commonly see. This is in colon cancer. A young man, a relatively young man, a 45-year-old man, he presented with bleeding while passing stools. So he had a family history of colon cancer. So this should ring a bell in your head. And investigation showed that he was a stage 4 cancer. He had lung and he had liver metastasis. So the first step we do, like I said, is first you take out a biopsy, and we did a colonoscopy and we took out a biopsy, and that actually confirmed adenocarcinoma of the colon. So now one of the tests we do nowadays for stage 4 colons is something we call MSI testing, or microsatellite instability testing. And he underwent this MSI testing with IHC. IHC is a very simple technique to find out MSI. And we found that he had MSI-H, or deficient mismatch repair genes, which we call DMMR. So whenever we see this, this is one of the conditions in which an immunotherapy drug, which is called as pembrolizumab, has actually been approved. This patient actually refused chemotherapy. He did not want to go on to chemotherapy. He was given the option of immunotherapy, and he went on to receive immunotherapy with this drug pembrolizumab, and he did relatively well. So this pembrolizumab again is a very expensive drug, and this is I've illustrated the situation just to show this was the first time in the history of FDA approvals that a drug was allowed to be approved in not a tumor site condition, not like breast cancer, not like colon cancer. It was approved based on a gene finding. So it was said that any patient or any tumor who had an MSI-H or a DMMR could be given pembrolizumab if he was not responding to the initial treatment, or if he had refused initial treatment. So this was one of the landmark FDA approvals where a gene test determined a drug use. So this is one of the very good indications for that. So the last case study I'm going to talk about is in ovarian cancer. So this is a 77-year-old elderly lady who was previously treated with ovarian cancer. So she had a history of ovarian cancer 2 years back. At that point of time, she was treated with surgery and chemotherapy. Unfortunately, the disease came back, and it came back in her abdomen. So now, at this point of time, what did we do? We sent out a blood sample from her for BRCA testing. So BRCA 1 and 2 testing. So this is something which is uniformly done in ovarian cancer patients. So she was found to be positive for a deleterious BRCA2 mutation. So again, you repeat a course of chemotherapy, and then after chemotherapy, the current approved indication for PARP inhibitors. So this patient went on to receive maintenance therapy with a PARP inhibitor called as olaparib, and she's doing relatively well. So these are 5 illustrations, very simple illustrations. There are far more complicated situations where we use precision medicine, but I think I would like to see what kind of questions you ask, and then we will move forward from there. But any questions right now? So based upon the clinical studies, do you get a feel of what happens in the hospital? Hello.
Dr. Pragya, I just have one query.
Please tell me.
Out of all the patients you get, how many of the cancer cases actually relapse? Or the patients come back with a new type of cancer or a metastasis in general?
So there is you can't put a number on that, because of course it differs between tumor types and it differs between patients, and that's the whole idea of this talk. But unfortunately, so stage 1 and stage 2 patients rarely relapse. 80 to 90% of them do not relapse. If you're looking at stage 3, almost 50% of patients would probably be coming back to your clinic, sometimes even more depending on their tumor types and adverse features. And in stage 4, you only treat them for control of disease. It disappears for a while, and almost everybody will come back with disease. So, in a sense, a substantial amount of patients do relapse. I would say at least 50% of patients would possibly relapse.
Thank you, ma'am.
One of the reasons for that is we detect cancers late. We come in 3rd stage and 4th stage. So that is another area where if we try to detect cancers earlier, then maybe we can prevent these patients from coming back by treating them more effectively.
Thank you, ma'am.
Any other question? Thanks, Dr. Pragya. We were all working in a research which is just in air, but after your presentation, we are really liking the way where it has to get aligned to the application or to the patient level, and how we can make really a better one. The hard work that we have put in, how it can definitely impact to the society and to the doctors. And this was wonderful, and thank you very much again for giving this opportunity. And now students has to take the best use of Dr. Pragya and get all the things clarified, and then we can move towards hackathon.
Any other questions?
Doubt?
Like to introduce Dr. Bhavani, who is a pathologist. She is the medical doctor who is working in our lab, and she is also there, and she will be also in the panel right now to discuss about the problems. So I just want to introduce Dr. Bhavani and Dr. Swarnamay Patra, who is also there. They will all be together along with the questions, and then they will continue with the panel discussion.
Yeah, tell me.
A recent study has shown that it can be used against the breast cancer cells. So can't we
It was breaking up. Can you repeat that, please? It was breaking up.
Ma'am, so recent study has shown that venom of the bee can be used to treat breast cancer. So
Again, I didn't get that question. Can we put it in chat?
Dr. Pragya, I think I can, this is Bhavani. So at the outset, I really like to thank you. Your talk was really good. I think the question that was being asked was in a recent lab in Australia, it's a recent study in Australian lab, which has shown that the venom of the honeybee has shown promising results in treating HER2 positive breast cancers. So they are touting it to be kind of a revolutionary thing, and I think that is what the person who wanted to ask the question was aiming at. That's what I think.
Sorry, I couldn't hear the question. Sorry, I'm not aware of that particular development. But it is not unusual to see that a lot of our drugs are actually taken from natural places. Like for example, paclitaxel, which is one of our major drugs that we use across tumor types, is actually taken from the bark of a tree. So I wouldn't be surprised if the venom of a honeybee actually had something against HER2 positive breast cancers. Maybe we should investigate that a little more.
And Dr. Pragna, I just wanted to ask, so in the lab that I used to work in, so we were investigating something called as a tumor mutation burden. So for people who don't know, tumor mutation burden is nothing but the burden of somatic mutation in the coding region of the tumor genome. So that was touted as a rational target for immunotherapy. So I wanted to know, have you been able to incorporate it into your guidelines while treating patients? Has it been incorporated, or is it in still nascent status?
Internationally, yes. In India, no. In India, we still don't have any lab. To the best of my knowledge, there is no lab that has a standardized TMB test. But internationally, there is a lot of debate as to what level of that mutation. Should it be more than 10? Should it be more than 20? At what level of that mutation should we be giving immunotherapy to these patients? So there is a lot of talk about it. Internationally, yes, tumor mutation burden is seen as a high tumor mutation burden is seen as an indication to use immunotherapy for these patients, but it has still not been standardized. And to date, in India, there is no lab. But when we send our tests abroad for NGS, we do get back some feedback about tumor mutation burden. But so far, all my patients, it has been negative. So I cannot give you too much of insight on that. But yes, that is a very good for active research.
Excuse me, ma'am.
Yeah.
Ma'am, I actually have a faint memory of reading somewhere that during metastasis, the circulating tumor cells, they actually, with the help of proteins called integrins, they adhere to the extracellular matrix,
Yes.
and they're able to thrive more and spread. So, is there any way to target this set of proteins called integrins? Is there anything that's happening as of now?
Even I vaguely remember that drugs that were tried to be targeted to these integrants turned out to be too toxic for clinical use. So it was actually disbanded. But maybe if we can find less toxic alternatives, maybe we can move from there. But if I remember right, all these drugs that target this extracellular matrix, they were found to be too toxic for clinical use, because there is no specific, see, like you have HER2 amplification is preferentially going to go and sit onto the tumor cells. Unlike that, drugs that target integrins or proteins in extracellular matrix are not confined to tumor cells alone. They are there in a number of normal tissues as well. So there is a lot of toxicity with these drugs. So if I remember reading right, those drugs are extremely toxic and not considered for clinical use.
I would like to add something to
Thank you,
this.
ma'am.
Yeah, sorry. Continuing on like what she said, are there any drugs available for like the pathways caused after the integrin binds to the ECM? So you have the whole ROS pathway and all that happens after that. And I think you mentioned
ROS
that being as
inhibitor is
a
there.
testing.
Yeah,
Sorry,
a
ma'am.
ROS inhibitor is there. We
Yeah.
use a drug called as crizotinib for it.
Okay.
Yeah, but for that we do a ROS gene testing. We don't test for the upstream molecules. We test the ROS gene, and if ROS gene is found to be abnormal, then we use this drug called crizotinib, which has some benefit. I wouldn't say miraculous benefit. It has some benefit in these patients.
Okay, ma'am.
Raina, I would like to add something to it. This is Dr. Charita. So I work with Dr. Pragya. So the thing is that we had done some in vitro tests with respect to beta 3 integrin in ER positive breast cancer cells. So you have this commercially available cell lines like MCF7, which are ER positive. So we could see that beta 3 was highly expressed in this MCF7 cell lines. We could inhibit it with integrin inhibitors, but when we took out some of the primary cells from patients, so we saw that it is being expressed, but the inhibitor that we were trying to use it to kill those primary cells, it was not killing these primary breast cancer cells, which are actually replicate of the patient tumor tissue. So we found that there are multiple mechanisms along with
Yes.
integrins that are being upregulated. So you have to kind of, HER2 inhibitors like lepatinib, you have to use to, kill those primary cells. So whatever we do in the in vitro experiments are not really the replicate of what is being in a real scenario when we come to treating the patients.
Okay, ma'am.
So,
Got it.
Dr. Pragna, we have a question from YouTube actually, and one of the viewers there wants to know how efficient is this exon sequencing in detection of cancer and how quickly can it be done for individual patients.
Can you?
When you try to identify mutations using exon sequencing, the viewer wanted to know how accurate is that and what could be the cost and timeline for such tests.
Hello.
Was my question audible?
It was breaking up in between. Can we type it?
Okay, I just do that. I just copy
Yes.
paste the same question from YouTube.
Perfect.
Question.
Tell me.
So, in the cases where there is a resistance to, let's say, personalized medicines, so there's a resistance to the drugs given by the cancer cells as they like further mutate, what happens then? So, do you change the medicine, or do you have to redo the tests, or?
Okay. Yeah, so that's a good question. So whenever we suspect resistance, we test for drug-resistant mutations. We do that very commonly in CML, where we look for imatinib-resistant mutations. We also do it in lung cancer, where we look for EGFR-resistant mutations. So we have to retest. We have to identify what type of drug mutation is there, and we have to tailor the treatment to drugs that are sensitive for that particular mutation. Yeah, I can see the other question now. It says, what is the accuracy and cost effectiveness of exon sequencing in detect related cancer related mutations? Cost effectiveness very questionable. I'll go to the second part first. So, like I said, in majority of patients, we may not be able to find a cancer-related mutation. Second, when we target it, the target may not work against mutations. So, roughly, I tell my patients that possibly only 1/3 chance that you might actually, this test might actually help you. So, the cost of it currently in India for all these tests that I talked about, foundation testing, and foundation medicine and garden is close to 2.5 to 3 lakhs, so which is a lot of money. So most patients do not go for these tests. There are very few who actually say, okay, I would like to take that 1/3 chance and see. Accuracy, I think, is high. Like I said, the specificity of the test is quite high. It is a sensitivity and the cost that are possibly the issues over there. So accuracy of these exon mutations are high. But the point is, after finding the mutation, and by blocking that mutation, are you actually controlling the most of the studies that say yes, there might be some survival benefit of this testing in these patients. But accuracy, yes. Cost effectiveness, questionable. Thank you. Yeah.
Hello, Dr. Pragya. This is Ravi Raj. I have a question.
Tell me.
How these kinase inhibitors are effective in treating this cancer? Kinase
Yeah.
inhibitors.
So it is a downstream signal. So
Okay.
EGFR goes through a tyrosine kinase.
Okay.
It goes through that, and then it goes downstream to activate the cell. So when you know
Okay.
EGFR is mutated, and that is the one that is a driving pathway for the cancer, you give a drug that blocks the downstream signal. So once you block that, then the tumor growth is controlled.
How effective it is?
Quite effective. So in lung cancer, we've been using TKIs as in tyrosine kinase inhibitors
Okay.
across the board for the last 10 years. And
Okay.
there is like to give you a more recent example, there is this drug called osimertinib, which is a third generation TKI, which we use for lung cancer.
Okay.
Previously, patients with stage 4 lung cancer used to not live more than 1 year, 1.5 years at the most. And with this drug, most patients are living more than 3 years, which is a landmark change in their life history.
Yeah. Thank you.
It is quite effective.
Yeah. Thank you.
Sir, most of the cancers has this proliferating capacity. Mainly it is by the MAP kinase pathway. So most of the kinases that are being involved in this pathway, so the biology of the cancer is driven by these proliferating pathways,
Yeah,
where most of the kinases are being involved.
correct.
So that's the reason TKs are specifically, effective.
Yeah. Thank you.
Dr. Pragna, just one more question. I wanted to know, there was a recent study by the Institute of Curie. What they showed was, I mean, this was in the wake of all this immunotherapy treatment and the markers for it, that is the PDL1, MSI, and tumor mutation burden. So they embarked on this thing to see how effective it is. And we know immunotherapy actually pulls back the tumor from being refractory and even advanced stages. But and is seen only in 20% of the cases. But in the other 80%, wherein it was thought that it would be ineffective, or it turned out to be that it actually has an adverse effect. Just to give you an example, they tested it on lung cancers. They saw that in 20% of the cases, the patients responded beautifully, even the advanced ones. But in 80%, they saw that actually it led to high proliferation of those cells, leading to a rapid advancement of the tumor. So, in your clinical practice, if in the usage of immunotherapy, have you come across any such scenarios?
Hello.
Hello, were you able to get the question? Sorry. Hello?
Yeah,
Yes. Can you hear me now?
Or Dr. Bhavani, maybe you can leave a question in the chat box so that.
Sure.
Yeah, I think the internet connectivity is a bit slow, so it is better if anybody has any questions, it is better to put it in the chat box. Maybe we can move on to the hackathon problem and then take up the questions. By then, everybody can actually type it and put it in the chat box, which Dr. Pragya can take it up after the question.